consultative surgeries. Inpatients require admittance to a hospital post-operatively. Inpatient procedures are often very extensive and they're like a long procedure. Categories are elective surgery, surgery that the patient chooses to have, somebody with degenerative joint disease of their hip, has had pain for years, they're electing to have their total hip replacement. Bariatric surgeries are elective. Hernia repairs, you know, the hernia is protruding, it's elective. It's not life or death to have it removed. Sometimes it might be. Tonsillectomy, they've had strep throat for the past 12 years, they're finally getting their tonsils out. So they're elective. Cataracts are also elective. You can choose to see better with getting the surgery. Urgent surgery, although necessary, it might be scheduled at a later time. Gallbladder, you know, you keep having gallbladder attacks, so you can have it done now or later. So it's urgent, but you don't have to have it done right now. Some of the orthopedic ones, kidney stones, you know, having the kidney stone removed, that would be urgent, but not life-threatening or emergent. Tumor removals, you know, depending on if it's cancerous or not. Sometimes you might need radiation first to
Shrink.
lessen, to shrink it,
To shrink.
Just go.
That's right, keep it on.
I know. To shrink the tumor before you were to extract it, it's just easier to have it that way. Emergency is unscheduled and done immediately. To usually save a person's life or save a limb, you know, a trauma or something like that. So a ruptured appendix would be emergent. A colectomy when you had like a perforation of the bowel from a tumor or a diverticulitis that perforated, you would need a colectomy right away. Bowel obstruction, you would need a small bowel resection. Gunshot wounds to vital organs would be an emergent surgery to fix it, to extract the bullet and to fix whatever the bullet destroyed. Surgical team member overview. So here are the sterile team members. Surgeon, surgical assistants, the scrub nurse, surgical tech, and OR technician. The surgical team members are the ones that work in that sterile field and have the responsibility of maintaining asepsis throughout the surgical procedure. It includes the OR table and the area closely surrounding it. An equipment stand that is conveniently positioned close to the patient and the instrument table. When the patient isn't sterile, we aren't sterile. Do they call that stand anything, Laura? A Mayo stand? Do they call that?
Mayo stand, yeah.
I never heard of that until this textbook told me.
I wouldn't know it either, except for it's labeled.
Oh, it's like a brand name, I guess.
Now it's like somebody went around with a big label maker.
Oh. It might stand for something. I don't know what it stands for, but it might stand for something. Mayo table. So that's sterile too, with all the equipment that's on it. The scrub nurse gathers supplies and sets up the sterile field, counts with the circulating nurse, maintains sterility, anticipates the surgeon's needs, and passes instruments back and forth. The surgical nurse is in charge of observation in breaks in sterility. So if something's touched the gown, if something's touched, you know, below the belly button or above the breasts in terms of the surgeon's hands or whatnot, that person needs to, the surgical nurse needs to, the scrub nurse needs to call them out and say, you broke sterility, go fix it, you know, go gown up again. Scrub nurse can be an RN, an LPN, an aide, or a tech. They're all called scrub nurses. Surgeons responsible for the pre-op care, diagnosis, selection of the surgery that's needed, and the performance of surgery. They control the OR and manage the post-op care. The assistant does just that, assists the physician. It's usually another physician, or a third-year resident. Nothing younger than a third-year resident is gonna be participating in the surgery, supposedly. That assistant needs to assume the lead role if the lead surgeon can't do it anymore. Passes out, has a heart attack, has to poop, I don't know. So whenever the lead surgeon can't, the second person stands in. Non-sterile team members, the anesthesia provider, the circulating RN, unlicensed assistant personnel, the OR director and coordinator manager. The anesthesia provider doesn't have to be sterile because they're usually at the head of the table, at the head of the patient rather. It's usually an anesthesiologist or a certified registered nurse anesthetist, CRNA. Initially anesthetic agents are administered and they're monitored throughout the surgery. Vital signs have to be monitored throughout the surgery, and that's something that the anesthesia provider is in charge of, whether it's the nurse or this physician, anesthesiologist. The physician, nurse is the registered nurse anesthetist. Circulating RN observes the surgical procedure from a broad perspective, assists in getting things that are outside of the OR, bringing them back in. They're not sterile, but their hands would be sterile in giving new equipment to the surgical team around the bed, or the team rather. Unlicensed assistant personnel work under the assistance of the RNs that are in the room, and are, fetch this, get that type of things. The OR coordinator and manager, just responsible for the room itself, might not necessarily be in the room, but they're, the ones in charge of making sure all the equipment is serviced and that everything that's needed is there, because they're in charge of the budgeting, the OR director or coordinator. Sometimes they're an RN, doesn't have to be an RN now. Circulating nurse must be an RN, which I think is weird because the scrub nurse doesn't have to be an RN, but a circulating nurse must be an RN. The ultimate client advocate, looking at things from the outside in, making sure everything's going okay. Maintaining accurate records, it's really important that what goes in must come out in terms of sponges and whatnot, that everything's counted more than once to make sure that everything comes out. A lot of the sponges have a radio opaque thread in them, so if the count's not right and you just can't see anything, they'll take an X-ray of the patient to see if something's hiding in there, like it might be under an organ or something, to see that indeed there's still a sponge in there, so that radio thread will pop up, and then you'll know where to retrieve that last sponge from, or last sponges from.
Is that, would that nurse say they needed something that wasn't in the room, like a tool or a piece of equipment, would they run and get that? Would that be, they would do?
Circulating nurse, yes,
Yeah.
anything that's outside the room. Other people that are in the room too, it's actually on the next page, I think. Sales reps, so new equipment, and then medical shows you do the sales reps too. That one, the resident with that crazy oncologist, or no, the crazy, I can't think, I haven't watched the resident, it's been awful.
She was an oncologist.
But the device that killed the kid,
Yeah.
and everybody was up in an uproar. But sales reps are often in the room explaining how to use equipment. The doctors might have watched videos, but they might not have seen and had a handle on the equipment or the piece of, maybe there's a new, maybe there's a new, mesh, or there's a new surgical clip that connects this way and not the way we're used to. The sales rep is just that, selling their product, wants this physician to use this for every one of their darn surgeries. So let's make sure they use it right, that there's a positive outcome for the surgery, that they'll spend money on this XYZ piece of equipment or device. Pathologist, for something, a tumor or cancerous, to take a piece of the tissue, and then the pathologist, isn't in the room necessarily, but will spin the blood, test the tissue to see, what cells, if there's cancerous cells or whatnot. Radiology, housekeeping, is in charge of cleaning everything up at the end. Equipment managers, maintenance, transport to get the person from the OR to the PACU down the hallway. Or if it's Roxborough, the PACU might be next door because it's such a small hospital. Everybody needs to work well together under stress, be motivated, competent, handle unpredictable events, work rapidly and efficiently.
How comes pharmacy's not on that?
Add pharmacy, because they're important too. Add pharmacy. Put that right at the top, like before pathologist, because morals. Get out the way, it wasn't in the preformed PowerPoint.
Well, I'm gonna call F.A. Davis, tell them.
Probably should. Probably do a bunch of nothing.
Either call Nancy Sullivan or Janice Hoffman.
Hoffman and Sullivan, I
Yeah.
guess. They went out of edited that after that. Says in the front.
And probably just more, but there at least no addition.
Yeah. Charge us another $400.
So national patient safety goals, cross out surgical fires, that is not a safety goal anymore. I guess that problem has been fixed. Patient safety goals have been retired when they're not a problem anymore. And new problems might be added to the patient safety goals, but surgical fires is not a goal anymore. The copyright of this textbook is 2017, so they were probably using 2014, 15 safety goals, so it's probably been a goal from back then. The new one related to OR is prevent mistakes in surgery. So the wrong site, wrong procedure, wrong person is what we're trying to prevent. So cross out surgical fires and write in prevent mistakes in surgery. I printed these out prematurely. So you conduct a pre-procedural verification process, so that timeout is what has to happen in order to prevent mistakes in surgery. Another one that could be applied to the OR is also prevent infections. So the longer somebody's kept open for surgery, the higher risk for infection is. So once somebody's opened, the goal is to close them up as soon as possible. So if you know it's going to be a long surgery, don't make it extra long. So the surgeon really needs to close as fast as possible, of course with getting everything that needs to be done, because there's such a high risk for infection. It goes against the hospital's statistics and the physician statistics too. You can actually look that stuff up. If you need your gallbladder out and your family doctor told you to go to Dr. Jones, you look up Dr. Jones and he has a 60% rate of infection, you might not want to go to Dr. Jones and find somebody else who's going to be like a 20% infection or less, There's just some doctors that, because they stay open for so long, they might be very thorough, but the fact that they're open for so long in a sterile environment, it doesn't matter, it's just a high risk for infection. So you gotta try to afford that if you can. To prevent infection, you really need to limit traffic throughout the suite. So really the circulating nurse, the other folks that were in there, like the pathologist, if they're in the room, the sales rep, they're not up close and personal, they're sort of away. They do have a mask on, so they're not coughing into open wounds and whatnot. 3 zones, unrestricted, semi-restricted, and restricted, they mean exactly what they say. Unrestricted area are gonna be the outskirts. Semi-restricted is gonna be within like a 5-foot area of the table. And restricted is when you're gonna be right up against the table, and, you know, you have to really be careful with, you know, not putting your hands below your belly button or above your chest, and, not reaching over the sterile field improperly. Safety in related to surgical fires, could be like the laser surgeries with eyes and whatnot, could have, possible fires, possible fumes. Safety, with, latex allergies, you wanna make sure that the person doesn't have them. All the, equipment, you know, equipment could overheat, oxygen's flammable, you're gonna have oxygen, in the room, so it's all things they have to worry about. The sterile drapes, you know, if you have, the drape sort of can be like tented, so that's an area that oxygen can be like trapped. So if there's a spark from the cauterization of closing a vessel, you know, OR fires are not uncommon. They're not common by sense of the word common either, but it's not even like they're not going to happen because of the environment itself. This here is a surgical safety checklist from the World Health Organization. You know, time in, signing out at the end, you know, all the important things. The patients confirm the identity, their site, their procedure, their consent. Before, at the end, before the person leaves the OR, all these things have to be, you know, documented. Any equipment problems that need to be addressed, that the specimen that needs to go to the lab is labeled and actually sent to the lab and not sitting somewhere forever. The name of the procedure recorded, the surgeon's signature at the end. Drawing a lab or I had an old student call me for advice the other day. Not for this, but she mentioned this in her problems with her place of employment. There was an order for like a urinalysis on one of the kids in her unit. She works at a psych hospital. And the order was written like June 20th or something. And I don't know how I didn't ask her how she found it, but she ended up getting the urine and sending it like August 15th, like almost 2 months later. And I said, well, how is that missed? She's like, I don't know, it happens like all the time. And like, why wasn't the physician who ordered it looking for the results either, you know? And I just thought that was like really crazy. That wasn't what the advice she was giving me, it was something else totally unrelated to that, but she was just like, all the problem. You wanna work in a safe environment, you wanna work where when you tell your boss that this happened and how can we troubleshoot this, that doesn't happen again, like, can we have like a chart of some sort, can we make a chart so these things aren't missed? And like, her manager just like poo-pooed her, like, she's just trying to help, you know, and trying to, like, that's like a missed error, you know, a missed order, like, it was just totally neglected for almost 2 months.
Yeah, because a urine, that's just a couple of days, you know, after, unless it's frozen or something.
Well, no, it was never collected, she collected it, it wasn't sitting around.
Oh, okay.
It wasn't sitting around. I got on that topic, meaning like if you draw something, don't let it sit around. It usually needs to be refrigerated or taken care of, you know. Environment of the operating room, a lot of physicians like it cold. Some like music, some don't like music. Some like loud music. Health and hygiene of the surgical team. They've scrubbed in. Surgical attire is clean, not sterile. Surgical scrub done before donning sterile gown and gloves. So we try to do surgical asepsis as much as possible. The health and hygiene of the team, the health of the team is important in not contaminating, you know, you don't, just like, you see signs when you walk in the front doors of the hospital, if you're sick, don't come in here, and don't compromise the patients from you being sick. So it's really important to, not come to work sick. So the same thing with, so a person can get a hospital-acquired infection from a sick caregiver. And the surgical scrub, when you're scrubbing for 5 minutes and hold your hands up in the air just so the water drips down to the elbows, that doesn't make your arms sterile. Your arms, they just can't be sterile. So guidelines, all materials in contact with the wound, the surgical wound, must be sterile. Gowns are sterile in front from your chest, and your sleeve from chest to level of sterile field. So they say belly button, but the table's, somewhere within inches of your belly button, hopefully. Floral shorts, not floral. I saw her giggle, that's why I pointed her out. Sleeves from 2 inches above the elbow to the cuff. Only top of draped tables are considered sterile, so the drapes that fall over the sides aren't sterile. The drapes that fall over when we did catheters, that wasn't sterile, just the top of the flat surface. Movement around the table must not cause contamination, so you really can't be leaning on the table, moving things around. When the sterile barrier is broken, the field's contaminated, so the sterile field has to be constantly maintained and washed out, so you're not screwing it up. Prepare as close as possible to the time of use, so that's prepared right before the surgery, so it doesn't sit and wait for the surgery at 2 p.m. It's done before the surgery, so because once you leave that sterile field, you don't know what's happened to it. So priority assessments and procedures, the preoperative assessment, patient's knowledge of the surgery, complications and interventions, validate, confirm, informed consent is obtained, and know about the patient's level of anxiety. We might be giving them something in their IV when we're giving them the anesthesia preoperatively to calm them down, a sedative. Surgical pause is that timeout to verify the important information prior to the procedure. It's done prior to the procedure to verify correct patient, correct procedure, correct surgeon. You're not gonna surgeon in the wrong room. Surgeon is gonna do a knee replacement and the room he walks into is the one that needs the kidney removed, that's, all that stuff seems like, we can giggle, but it's happened. Correct laterality, what side of the body, correct equipment, correct imaging studies.
Keep going.
Surgical scrub, prevent surgical site infections by doing a scrub, follow hand hygiene and hand scrub procedures. Even though we need our hands to do the surgery, it's a means of, or a portal, or a transmitter of infection to the patient. The warm, moist conditions inside surgical gloves are an ideal environment for funk and the rapid growth of microorganisms. Donning of surgical attire, important in reducing the risk of postoperative infections. And there's several levels of surgical attire. You have the surgeon, the scrub nurse, the assistant, surgical assistant, all need to be at the highest level of scrubbing. And we'll have everything in from booties to hair net or hair cap, not net, mask, goggles, surgical gown. Without anesthesia, most surgical procedures would not be possible. The goals of anesthesia are those 5 things: amnesia, you don't want to remember what happens during the surgery, analgesia, depression of reflexes, so people don't wake up during the surgery, and people don't kick at you when you're using a hammer on their knee to put a new, titanium knee in a patient, muscle relaxation, and manipulation of physiological systems and functions. the selection of anesthesia depends a lot on the surgery that's being done, how long they have to be out for, what the anesthetist prefers, what the surgeon prefers, what the goal is, you know, is it more pain management, is it more, sedation? How long the client's been MPO for, like if it's something that's an emergent surgery and they just came back from Burger King or something, you know, they're gonna be different anesthesia than MPO for the last 8 hours. Oh, you gotta be